Good evening and welcome to I'm Chris Parnell.
Reporting from Moscow.
Tbilisi.
Times Square.
May your dreams be your only boundaries in life.
Hello and welcome to Living Well. I'm William Kinley. Summer's quickly approaching and that means it's time for shorts and swimsuits. Men and women who have varicose or spider veins can feel uncomfortable knowing their legs will be showing and that those veins will be seen. Interventional radiologist Dr. John Roberts with Memphis Vascular Center joins me today to talk about what these veins are and how you can get rid of them. John, welcome to Living Well.
Thank you.
Why don't we start first with just talking about what you do as an interventional radiologist?
Well, basically an interventional radiologist is a diagnostic radiologist who spent one additional year in fellowship learning how to do procedures.
Okay, so a diagnostic radiologist, tell me a little bit more about what that means.
Well, diagnostic radiologist primarily is someone who looks at x-rays, CAT scans, ultrasounds, and does some basic procedures. And then interventional would be the more, elegant procedures, so to speak.
I see. That sounds like a good adjective.
Yeah.
So would it be fair to say that a diagnostic radiologist is interpreting what might be going on, whereas an interventional radiologist would carry that forward into treatment?
Absolutely, yeah.
Okay.
A lot of what we do as interventional is treating. Some of is diagnostic, but...
Okay. Well, what types of procedures do you perform as an interventional radiologist?
There's a wide spectrum of things. We perform angioplasties in the peripheral arteries. We do procedures on the liver and the kidney. A lot of the new stuff is related to oncologic intervention, treating cancers, particularly in the solid organs. We treat fractures of the vertebra, treat blood clots in the legs, in the veins.
So it is a really wide array of impact.
Yes, absolutely.
So if you're working in the vascular system, you're opening areas up that hadn't had flow. Is that a reasonable description, or you're
closing things that have bad flow?
Okay.
Yeah, it could be either or.
Okay. So with vascular disease, or when you mentioned cancer, what are some of the things with cancer that you do?
Well, we have someone in our group who does a lot of treatment of liver cancer, and that usually is done in one of two ways: either going through the arteries and introducing the chemotherapy drugs and other agents through the artery directly to the tumor, or it can be performed through the skin using imaging guidance and putting a device in and like an RF radio frequency device to treat the tumor with heat.
I see. So getting very close to the tumor,
yeah,
versus an overall treatment.
Yes.
I see. What benefits does interventional radiology offer patients? I know you got into this a little bit, but I'm sure there's more.
Well, a lot of the things we do, we would call minimally invasive, surgery or procedures. And since it's minimally invasive, the recovery times for a lot of the things we do tend to be a lot faster than if you had to be opened surgically. A lot of the things we do are outpatients.
Could you give me an example of something that historically or in the past has been done as an open surgical procedure that you're able to handle with minimally invasive technique?
We treat women with uterine fibroids, and the way we do that is go in through the artery, go to the arteries that supply the uterus, and we're able to block off the blood flow to the fibroids. The patients are in the hospital probably 4 to 6 hours max and go home, and the recovery tends to be fairly short, whereas hysterectomy or myomectomy may require an admission into the hospital, and the recovery tends to be more in the 6 to 8 week range.
So a big difference.
Yeah.
Now, are there only, like with that as an example, are there only a subset of patients that this treatment's applicable to, or is it broad like a hysterectomy would be?
We tend to try to limit the patients that we think are going to maximally benefit from it. Sometimes patients have other disease processes that can mimic the symptoms of fibroids, and so consequently we perform an MRI on every patient. That's the most exquisite way to evaluate the uterus and decide whether they're a good candidate for embolization.
I see. About how many of those procedures have been performed with your group since you started?
Oh, I would say I've probably done about 1,600 since 1998, and
wow,
there are several other guys doing them, so I'm guessing we've probably done 2,500 over.
And this is a permanent solution?
In general, it's permanent. Once the fibroids are dead, they're dead. Now, you could grow new fibroids.
Right,
That's pretty uncommon, though.
Right. Well, that's very interesting. That's only one example, but are there other examples of how you've seen interventional radiology change during your career?
Oh, well, so much of it is changed. A lot of the things we do now were things that maybe were done by other specialties, or were things that maybe because of our imaging guidance made the procedure a better procedure. A lot of that has to do with like vascular access, putting in central lines and portacaths, because we're so adept at using all the imaging modalities, ultrasound and fluoro. Sometimes it gives us an advantage. I tell patients, you want your doctor to cheat if it's going to help you, have less pain with the procedure or have better results. So we cheat on a lot of procedures.
Well, and I know you mentioned vascular access, but I know at Methodist Le Bonheur Germantown, the access program, if you will, is led by you guys.
Yeah.
And you want to talk a little bit about how that works now? Because I think it is unique in the field.
Well, previously it was more of a nursing-led service, and nurses don't get training to do procedures with imaging like we do, and by us taking over the service, we've been able to impart our wisdom and ability to them to where the service is now rendered a little better, and then we're there as a backup for the cases that are hard.
So it's more seamless.
Yeah.
That's great. That's one of the horrors I know patients have. I know I would have too, just going in for a simple phlebotomy, which is not what we're talking about, but multiple sticks.
Yeah.
No one stick, we all want one stick,
Yeah.
kind of regardless of what it is.
Absolutely.
What's in the future for interventional radiology?
It's hard to predict. Things, that we do now, as a resident, I would have never even dreamed would be things that I would be doing as an interventional radiologist. The whole field of phlebology and treating the varicose veins, that was not even on my radar screen. So it's hard to know, but I know that a lot of the things that are really being talked about now are things involving the oncologic aspect. So a lot of gene therapy, and so where we're going to evolve to, it's hard to say, but I have a feeling radiology, as it has been in the past, will be on the leading edge.
Has the specialty been as fulfilling as you anticipated when you made a decision to do your extra fellowship training?
Oh, absolutely. A diagnostic radiologist, you're reading images, you a lot of times don't even meet the patients. Being an interventional radiologist, you meet the patients, you treat them, and when you have success, it's and you make a difference in their care and relieve their pain. It makes a difference. So it's rewarding.
That's wonderful. Thank you. It's time for a quick break. Up next, we'll learn about interventional radiology and the conditions and diseases it can help. We'll be right back.
You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us, and the world will live as one.
Everybody needs a helping hand. Take a look at your fellow man and tell me what can I do today.
Hey, let me get that for you.
Everybody needs a helping out. If that ain't what it's all about, tell me what.
Thank you, young man.
What can I
No problem.
do? What can I do today?
Courtesy. Pass it on.
I got it.
A message from the Foundation for a Better Life.
Welcome back. We're talking with interventional radiologist Dr. John Roberts with Memphis Vascular Center. John, thanks for all the info you gave in our last segment. Maybe getting a little more specific this time with peripheral vascular disease. I guess first off, tell us kind of what it is, and then we'll go from there.
I guess kind of in layman's terms, it's hardening of the arteries.
Okay.
Or cholesterol buildup in the arteries. But basically, the atheromatous plaques narrow the lumen of the vessel and reduce blood flow, primarily to the muscles is how we know we have a problem.
Okay.
Typically a patient that has blockage in their leg arteries, when they walk a certain distance, their muscles become starved for oxygen because they're not getting enough blood, so you get pain either in your buttocks or your calf. You stop walking and it'll go away. As the disease gets further advanced, you'll start having pain all the time. And then at the extreme, you can even have ulcerations in your skin from lack of blood flow.
So your body's basically starving.
Yeah.
And then when you stress it by exercise, you're making it worse.
Well, actually, you're making the symptoms worse, but exercise is one of the treatments for peripheral vascular disease.
Okay. Okay. So you kind of want to work through it if you can, I guess?
Yeah, there's an old axiom. A third of people with peripheral vascular disease, their disease stays the same. A third will progress and a third will get better. And the third that get better are probably people who change their lifestyles. They quit smoking, they eat healthy, they get their cholesterol, in their appropriate range, and they exercise.
How much of this is just due to heredity?
A part of it is. Certainly there's a part, but
is it more so lifestyle, would you say?
It's multifactorial. It's hard to put one thing and say that's the real cause. I will say quite commonly smoking is high on the list of causes of peripheral vascular disease. But things like diabetes and renal failure also are morbidities that can affect it.
So you mentioned some of the symptoms. Are there other symptoms that would develop?
Well, you can have maybe cramps in your leg, but typically the pain with exercise is called claudication, and that's kind of the classic symptom that if you were asking a patient to describe their pain, that's the symptom you would get.
I see. If a patient is having those symptoms, or you have disease in your lower extremities, is it likely that you have the same narrowing in arteries like going to your brain, for instance?
There is a correlation, not always, but people with peripheral vascular disease certainly can have disease on their coronary arteries in their heart or in their carotid arteries going to their brain.
I see.
It's not a one-to-one correlation, but certainly makes you think.
Yeah, I would think so. That would be another scary part of it, I guess. Well, who should get tested for peripheral artery disease? And I guess as an addition to that, how do you test for it?
We just started a free screening at our office, and typically, we would go through a questionnaire and ask things about high blood pressure, cholesterol, family history, things like that, smoking. And then if you have any of the symptoms that would correlate with it, and if you flunk the screening, what we would do is just a basic ultrasound test where we measure the blood pressure in your arm and your ankle and see if the number comes back in a normal range, which is somewhere around 1.
Okay.
If you flunk the screening, we could either do a full ultrasound, or more commonly what we do is we go straight to a CAT scan of the arteries.
Okay.
Which is an outpatient procedure. It takes 10 minutes and has gotten really pretty good at identifying the extent of disease, how bad it is, whether you're a candidate for percutaneous therapy or if you really just need to go see a surgeon and have a bypass.
I see.
Yeah.
So with CT, you can actually determine the width of the lumen of these vessels?
For the most part, we can. Yeah. There are some limitations if the disease has a lot of calcium in it. The CT has a little trouble discriminating between the blockage and the actual lumen. So
I see.
But in general, it's a very good test. Most people, we don't have to do any other testing. We can use that as our diagnosing.
So now that you've diagnosed the patient and the patient does have peripheral vascular disease, what are the treatment options that are available?
Well, the first thing you can do is just treat somebody medically. And there are several different medicines that are made specifically to treat peripheral vascular disease. And that's probably, if the disease is not too advanced, it's probably the appropriate thing to do and try, a 3-month trial of medical therapy. If the disease is amenable, we have several things that interventional radiologists can provide, including balloon angioplasty, atherectomy, where you can actually go even through an artery that's completely occluded and recreate the lumen. And then occasionally we'll use stents to hold the artery open. Certain arteries respond better to stents than others, so we try to be judicious in our use of those.
So the balloon angioplasty, you place the balloon where the artery is restricted and you inflate the balloon and it squeezes open. I mean, you think of the physics of it. Does it just smash and open it up?
Somewhat. The way an angioplasty works is it basically tears the plaque kind of lengthwise and then smashes it.
I see. To create an opening.
Create an opening.
I see.
What we've seen in people who respond well to angioplasty, if we always use dye studies while we're doing the procedure. It may not look great at the time of the angioplasty. They come back 6 months later. That area has remodeled into a more normal lumen now. So we try not to let the way it looks initially be what dictates how successful we are, because we know that the body heals over time to where it can look a lot better down the road.
That's good. Well, coming up next, we'll finish talking about peripheral artery disease and talk about spider and varicose veins. We'll be right back.
When we don't talk, when we don't touch, when it doesn't feel like we're even in love, it matters to me. When I don't know what to say, don't know what to do, don't know if it really even matters to you, it matters to me.
Well, you're wrong.
I'm wrong. You're the one who misrepresented the facts.
The facts? Are you kidding?
Your proposal's ludicrous.
My
It's
proposal will
ludicrous.
go
It's
exactly the way I say it
Over
will.
my dead body.
I think Daddy needs a timeout.
Oh, that's the power of one.
Civility. Pass it on.
One grain of sand can turn the tide.
Welcome back. We're talking with Dr. John Roberts, an interventional radiologist with Memphis Vascular Center. John, just had one question from our last segment, and it may be the most important one, but why should folks that have peripheral vascular disease seek treatment?
Well, like we talked about, a third of those people, the disease is going to continue to progress. And there is a point where the disease is severe, there's no surgery that can be performed, no angioplasties, and the only thing that can be done is amputation. So early treatment can be preventative and prevent that from happening. And sometimes, patients just need a doctor to look them in the eyes and say, you got to quit smoking.
Sure.
And as hard as it is, it's either that or have your leg cut off.
So if you kind of carry folks along the continuum, first might be change your lifestyle, including stop smoking.
Yeah.
Next would be medication.
Yeah.
Next would be the interventions that you can do, minimally invasive types of things, and then if not, or the next would be surgery, I guess, and then the final thing, if nothing worked or you waited too long, amputation of the limb.
Yeah.
And we all want to avoid that for ourselves and for your patients, I know.
Yes.
Well, thank you for that. I think it's important sometimes that we understand the call to action for early diagnosis and treatment.
Yeah.
Wanted to talk about a different subject now, varicose veins and spider veins. I guess a good place to start would be, can you explain kind of what the difference is between the two?
Well, basically the difference between a varicose vein and a spider vein is just size.
Okay.
The pathology or the pathophysiology is basically a vein that's not functioning the way it's supposed to, and it's because the valves are not functioning and the blood's allowed to go backwards instead of staying in a forward motion. So they just start getting bigger because they have too much blood in them. And, in general, people with varicose veins tend to be people who are going to have symptoms. Spider veins almost always are just cosmetic.
I see. So it's just really the size.
Yeah.
That makes sense. And so when you see them begin to backflow, you talked about them expanding. They get larger in what sense? Kind of like a balloon, I guess, maybe?
Yeah, it's just kind of like taking a balloon out of the bag and you hook it to the faucet and fill it up with water. It started out, flat and small, fill it up with a balloon, depending on how much water you put in it, how big it gets. So, yeah.
Is there anything that folks can do to really keep either varicose or spider veins from happening to begin with?
Probably not. Maybe in spider veins, wearing support stockings, when you're up and about might help. So much of this is familial, genetics. So it's probably just something you're going to have, and it's.
So it's quite different than what we talked about earlier with peripheral vascular disease. Yeah. Really not. So in someone that had varicose veins, you wouldn't say automatically, that's a patient that's got peripheral vascular disease.
Oh, no. Now, I do see people that have both,
sure,
but that's just coincidental.
I see. I see. I wonder if sometimes folks might think that. Well, is there certain folks that are more likely to develop, men, women, active, not active?
Well, the majority of people with spider veins that seek treatment are women because they care what their legs look like. Women are more prevalent with varicose veins than men, but there are a large number of men with varicose veins.
I see.
And the majority of men who seek treatment are because they're having symptoms, pain, swelling, ulcers, heaviness.
Well, you mentioned treatment. What treatment options are available?
Well, historically, there were purely surgical options. About the year 2000 is when laser ablation became available to treat varicose veins that were due to saphenous insufficiency. And so, the key with varicose vein therapy is first performing a very detailed ultrasound to determine what the cause of the varicose veins is. Sometimes varicose veins are just varicose veins. Those we just treat with sclerotherapy. But if it's coming from a bigger vein on the inside, you don't want to just treat the varicose veins, you want to treat the problem. So we have a couple of devices. We can do radiofrequency or laser. Both of those work very well and treat the vein by basically causing it to clot off on purpose.
I see. So you close off the flow to that area.
Absolutely.
And you have collateral flow that feeds that area of the body, so not a problem?
No problem.
Well, that makes sense. Well, once you have this treatment, how quickly can you get back to your daily life?
That afternoon, that day.
So it's really quick.
Yeah. The only thing we prohibit is soaking in hot tubs.
Really?
Yeah.
And is that because it'll open it potentially?
It has the potential of opening up. That's if people come in with a clotted off varicose vein, the phlebitis, so to speak. The way we treat those people is tell them to get in a hot tub and take aspirin. So those are the two things we tell them not to do once we've done a treatment.
And is that just right after the treatment, or?
We tell them, 30 to 60 days.
I see, till it kind of heals up permanently.
But we send people back out. They're in a compression hose. We tell them to exercise, go to work. You just do whatever you want to do.
So this really is a permanent cure.
There's going to be some treatment failures, but most of those can be retreated, and the success rate is very, very, very high.
I see, and it sounds like it's much less invasive than treatment options that were available before.
Oh, absolutely, yeah.
Well, that's great. Well, I really appreciate you being on the show today. I know our audience appreciates it, both hearing about your background and education as well as the different disease states and things that you can treat. I appreciate you being here. Thank you.
Anytime.
That wraps up our show for today. I hope that Living Well will help you and your family lead healthy lives. Thanks for watching. I'll see you next time.